thinking this. So, hydration. This is interesting. There are very few areas in medicine where there's quite this humongous difference in treatment. In a hospital setting, the patients that are exactly the same, every single one of them generally, unless it's been influenced by hospice, will be getting IVs, at least at some rate. In fact, some people in the hospital are getting IV fluids even when they're trying to diurese them, which boggles my mind, but that's another issue. And then you come into hospice, and traditionally, absolutely no one ever gave hydration. It's bad. So you have one group of people saying this is bad, and other people saying it's necessary. That no wonder there's a lot of confusion and angst about this among families and patients. Well, it is not that simple. I mean, there's no simple answer to this. There are downsides of hydration. Obviously, you can overhydrate people, and we see this. We see people suffering in CHF and dyspnea. You can put people into flash pulmonary edema. Having to do some kind of lines can really limit their mobility. It may mean they end up needing restraints or some problems like that. IVs are painful to put in, and for many of us, they're painful if they're just in there. My wife was very funny, but she went through she went through our first child, which was extremely difficult labor. Josh decided to come out quite at a difficult angle, so it was extremely difficult. She did it without any medication at all. Over 20 hours, unbelievable. But what bothered her by far the most was when they got concerned about the rhythm and they put in an IV, and she was far more concerned about the pain from the IV site than the pain from the baby, which is my wife, but I tell you, this can be quite distressing to people. And you get potential for infections, potential for the vein blowing. You need to be changing these. It's often very difficult to put it in someone who's dehydrated, who's elderly, may have had a million sticks in the past, and then maybe fighting you because they don't want you hurting them, and they're confused and they don't understand what's going on. So it's not an ideal option. And the final thing is, a question is often brought up, and is sometimes used kind of as a trump card of, we don't want to prolong the suffering of this patient. They are suffering right now. They're delirious. They're unhappy. We don't want to prolong this. If we give hydration, we may prolong the dying process. That would be bad. Our goal is certainly not to prolong the dying process. But that's not the whole story. Hydration can improve and even resolve delirium. It can improve agitation. These have been shown clearly in studies, opiate-induced neurotoxicity, thank you, and even pain. There have been some studies on pain. Now, I think at least one of these studies which did that, I will say they had several interventions of which hydration was one key component. Decreasing benzos was another, so that may have contributed in a big way as well. And also, but some of the improvement in pain may have just been treating the opiate issues. Can't even say that right now. There's also evidence that if you put patients who aren't eating and drinking adequately on a steady dose, steady amount of medication, steady amount of fluids, a liter a day, which is considered to be about maintenance. It's considered, if a dying patient is just lying there, they're going to lose a liter a day from just breathing. And so if you give them a liter a day, you're not going to overhydrate them. And maybe liter and a half is about what it is, and that can prevent them getting more dehydrated. And there are hospice places in this country and in Canada that will do this routinely. Pretty much everyone will just get put on this. And that's been shown to seem, along with some other things that they did, was helpful. Most of the patients were cancer patients. In that case, it did not prolong the life. That said, I think it clearly, I think there is a role for it. I don't use it much in the prevention thing. I think most of the time, my view is at this point focused more on the treatment. But you can get people feeling better, and it can in some cases keep them alive, unquestionably. If you can resolve them, and so that their delirium, and so they start eating and drinking again, and they're feeling good, you can give them quality life, and that's really what it's about. And so, okay, we want to try to avoid these negatives, but we'd like to try to get these things. So how do we do that? And I will say, this talk is a little longer than I expected because I did add on a lot, but I promise I'll be done by 5. And if someone does need to leave early, I'm not going to be offended. So the question is then, when do we use it? Again, I think if they are clearly in that dying process, and it clearly was a result of an irreversible thing, it is not necessary. Although again, you could make a case that, especially in a cancer population, that doesn't prolong life in that case, and it's not unreasonable to do. I generally don't do that unless I consider it if it's very distressing. But generally, if they're clearly dying, we're not going to be going there if it's one of the symptoms of the dying process. But generally, I think it's a good idea to consider a trial in delirium, unless they seem to be well hydrated. How you determine that can be a little challenging. There are certain ways which have varying degrees of reliability. Certainly, if someone has sunken eyes and their skin tense up and stays all up, and all their mucous membranes are dry, and then they're probably dehydrated. You could often just asking how much they've been drinking, trying to get it, and they're peeing in particular, how much they're urinating, can be particularly helpful in figuring this out. Keep in mind, though, that just because someone has fluid in their extremity, fluid edema, does not mean that they are adequately hydrated, ironically. You can be intravascularly volume depleted, and your albumin is 1.1, and any fluid you do have is just leaking straight out. And so sometimes even those patients may benefit. So, again, and the other thing is, using hydration in delirium can decrease agitation even if it doesn't resolve the delirium. And so it may prevent the agitation, which is the really most distressing part of delirium, which we'd really like to avoid. It can resolve, obviously, if you have opiate-induced neuropathy. I said neuropathy here, I wrote it. Neurotoxicity. That is a good time for it. And then other times maybe, if they're dehydrated and they're sick to their stomach. Dehydration can cause nausea for different ways, and sometimes I've had people feeling better and nausea resolving when you hydrate them. If they're dehydrated, the family is distressed, I don't think it's unreasonable in most circumstances to give a trial of it and see how they do. Depending on, and we'll talk more about how to do that. I'm not going to get into the thirsty thing. And there may be some other circumstances they're having symptoms from the dehydration. But I want to emphasize the concept of oral hydration. Encouraging people to take orally is key. This concept of oral rehydration therapy is used throughout the developing world, people with severe diarrhea. There they use something that's very similar to the really weak Gatorade, which is some of the more recent stuff, or just regular Gatorade diluted by half. And that's WHO, that's very similar to the WHO rehydration solution. And a mix of salt and sugar and water, if you take that in, it actually is actively taken up by the body, as opposed to normally it just kind of passively goes through and may take much more, and may be much more likely to precipitate vomiting because it stays. If your gut isn't working real well, it may stay in the stomach a lot more, and then if you keep taking too much, you may vomit it up. When if you take this stuff, it's much more likely to just be taken into the body right away. So encouraging families to give even Gatorade, very frequent small amounts, and just keep offering it to them. Now, again, there's a balance. We're not forcing them. We're not going to, if we force them, you need to do this, and really pushing it, I don't think that's helpful. But regularly offering it to someone. Again, if someone is starting to get a little delirious, they're not going to be asking about it. They're not going to be thinking about it. But if you hold it up to them and say, hey, would you like this? Oh, yeah. They're not going to be taking the initiative to do that a lot of the time. But if we are active in encouraging people to do that, that may reverse or prevent it from getting worse. I think that's I'd really encourage us to be encouraging people to orally hydrate as much as possible. Then the whole issue of other parenteral becomes a non-issue. Clysis. This is, those of you who've been around quite a long time probably used this previously, but this is an option that we've gotten to using a lot. What it is it's hydration subcutaneously. And benefits, it's very simple. I have had at least one situation where we taught the family how to do it, and they gave a liter every night for 3-4 weeks, and it's very, very simple. In that case, I think we changed the needles, but I know times when I think it was a different situation, but I think I know of at least one time when the family actually was involved in, well, maybe it was just subacute injections. Anyway, it's very simple, and family could theoretically even change the needles. I mean, it's that simple. It's very low maintenance. Again, it can be done in the home setting. You don't need fancy equipment. You just need an IV bag and a pole, and maybe a little drip monitor thing, depending on how you're doing it. Risks are minimal. It's not going to blow the vein. If it gets pulled out, they're not going to bleed all over the place. I guess the biggest risk is that they'll get the hold of that needle, but I've never seen that. Heard of one case where they dropped someone's lung, and I guess they must have taken the needle and put it straight in rather than on the skin. So don't do that. I think that's pretty extreme. It's basically painless. I talked to a bunch of nurses. The whole hospice sat around. All the nurses sat around and did this to each other. They all gave each other 500 cc bolus of normal saline, and did it under pressure. We'll talk about, and they said it felt a little tingly because they all got this pancake under the skin, but no pain at all, and no one in the room found a painkiller. It was just a little bit weird for some of them, but that was the worst, and that was under pressure, sitting on the bag actually. There are some potential problems with it. It is not great for really high volume or fast. There are some studies out with hyaluronidase, including recombinant human hyaluronidase, which is probably going to be ridiculously expensive, but that makes it so it can dissolve into the body much faster and go much larger area. But generally, I've never needed to do that. You do get this pancake, which can be a little weird, but I've never had anyone complain about that. You cannot use one of the buttons. It's not going to go through. It's just way too small. Depending on what you want to get in, you might use a moderate-sized butterfly needle. Those can work, and just put that under. There are some other ways it's been done, but that's the most common. So key things: we only use isotonic solutions. Normal saline is most of what we use. You could use D5 half. We'll use that occasionally. Lactated ringers. Do not use twice normal saline. Do not use D5W. Those can actually cause skin necrosis, and that is why people stopped using this, because they used hypertonic or hypotonic. You can give a 500 milliliter bolus, and the best way to do it, what's his name? Barrera gives us kind of funny story, and he invented various things, and he's come up with different things to fix all the different problems. He's done all kinds of things for this field, but he was trying to come up with a good way that if you put a blood pressure cuff on a bag, you constantly have to keep pumping it up and then readjusting it, and it'll fall off. So he's trying to come up with this nice thing where it'll come down, and finally one of his students said, well, why don't you just sit on the bag? He's like, yeah, very funny. Oh, wait a minute. Basically, you can just literally put it underneath the patient, and so they're putting pressure on it, and obviously it will just keep putting pressure on it until it's more or less empty, and that is a good way to get it in under pressure if you just want to get it in, or you can have someone sit on it if you want to. And it sounds funny, but it actually can work. And just doing 500 cc's at a site is typically, if you can do it under pressure. You can do 40-50 milliliters an hour continuously. That will give you an adequate basal rate, because that's 1 to 1.5 liters a day. You can give 100 milliliters an hour overnight, just for 10 hours. That way they can be off it during the day and they can have it at night. That's sometimes a nice option if you're going to do this for any length of time, which is rare in my